Assalamu alaikum. Hello, hello, hello. Today I would like to discuss about the topics of hematology. It's a very unique topic. Hope you would like to enjoy. Starts with anemia. We know that anemia can be divided into microcytic anemia, macrocytic anemia, and normocytic anemia. This folate deficiency, it is macrocytic anemia. In macrocytic anemia, there are two types of anemia. One is folate deficiency, another is vitamin B12 deficiency. In folate deficiency, what are the etiologies? Etiologies are chronic hemolysis like sickle cell disease, chronic hemolysis. This is important, sickle cell disease, poor dietary intake. If you take less amount of folate, if there is malabsorption syndrome, or like if there is gastric bypass, and if you take some sort of medication like methotrexate, which is known as antifolate drug, phenytoin, one of the epileptic drug, and a common side effect is gum hyperplasia. These two can cause folate deficiencies. What are its features? Features is there may be dyspnea, there may be fatigue, patient may be pallor, and there may be weakness. Dyspnea, fatigue, pallor, and weakness. It is one sort of macrocytic anemia. Poor reticulocyte response, low to normal reticulocyte count does not increase as there is anemia, so your bone marrow is trying to compensate, and you will see you can observe it uh, by seeing the reticulocyte count. So in here there is poor reticulocyte response, low to normal. There may be hyper segmented neutrophil. This is high yield hyper segmented neutrophil, and you will get low serum folate. As there is folate deficiency, so you give folate, so folic acid supplementation. How will you calculate corrected reticulocyte count? We can calculate corrected reticulocyte count by looking at the percentage of the reticulocyte given in the stem into hematocrit divided by 45%. Hematocrit divided by 45%. So given reticulocyte count, given hematocrit, uh, then it is divided into 45%. Already I have discussed you that sickle uh, cell disease can cause folic deficiency. Sickle cell disease can cause folate deficiency. Sickle cell disease is a chronic hemolytic anemia in which red blood cells are typically normocytic and normochromic with a compensatory elevated reticulocyte count. Without adequate folic acid supplementation or intake, chronic hemolysis can lead to folate deficiency as the bone marrow uses folate in an attempt to produce red cell. So folate deficiency results in findings of macrocytic anemia and hypersegmented neutrophil. Due to ineffective erythropoiesis, the expected reticulocyte count is absent or inappropriately low reticulocyte count is seen in this patient. This is high health, as sickle cell disease is a chronic hemolytic anemia, and in which red blood cells are typically normocytic and normochromic and with a compensatory elevated reticulocyte count. as in there is inadequate folic acid supplementation or intake. These chronic hemolysis can lead to folate deficiency, and bone marrow tries to use folate in an attempt to produce red blood cell as there is folate deficiency. So your bone marrow is unable to make enough erythropoiesis, and the expected reticulocyte count is absent, and inappropriately low reticulocyte count. Although this patient's reticulocyte count appears normal, it is lower than the expected for sickle cell disease. Hyperhemolytic crisis is a sickle cell disease refers to severe acute normocytic hemolytic anemia with an increased reticulocyte count. In hyper there are two types of problem in sickle cell disease. There may be sickle cell crisis. There may be hyperhemolytic crisis. In hyperhemolytic crisis, in sickle cell disease refers to an acute normocytic hemolytic anemia with an increased reticulocytosis. In contrast, this patient has macrocytic anemia with an increase without an increased reticulocyte count. In hyperhemolytic, there is normocytic normochromic anemia and with the increased reticulocytosis, but in this patient, like in patient with having sickle cell disease, there is macrocytic anemia with an increased reticulocyte count. Splenic sequestration presence with sickle cell disease as a rapidly enlarging spleen, abrupt anemia, and increased reticulocyte count. So splenic sequestration, there is enlarged spleen because all the RBC, when they pass through the spleen, they become trapped in the splenic sinusoid, and there is larger spleen, and maybe there is abrupt anemia and increased reticulocyte count. Splenic sequestration typically occurs in young patient prior to autoinfection of the spleen. Prior to autoinfection of the spleen. Then the next topic is hyperhemolytic massive transfusion protocol. Next topic is massive transfusion protocol. In massive transfusion protocol developed to standardize resuscitation as likely required in patients with two of the following: penetrating mechanism injury and a positive focused assessment with sonography. In trauma examination, evidence of hemorrhage. There may be systolic blood pressure less than 90 and pulse maybe more than 120. And in these patients with a massive transfusion protocol, 1:1:1 ratio is followed or to giving blood products like one fresh frozen plasma, one packed red cell, and one platelet to mitigate coagulopathy. Trauma itself can lead to coagulopathy due to dysregulation and inflammation. Trauma itself can cause coagulopathy due to what? Dysregulation and inflammation. Then the next topic, a very high yield topic, that is hemolytic uremic syndrome (HAS). Pathogenesis is E. coli serotype 0157H7 or Shigella dysentery. These two can cause vascular damage and can cause microthrombi formation and thus causing HUS. So, preceding bloody diarrhea, fatigue, pallor, bruising, petechiae, oliguria, and edema. Lab findings is hemolytic, as the name suggests, hemolytic anemia. In hemolytic anemia, there may be uh, schistocytes, helmet cell, fragmented cell. As the hemoglobin is broken down, so increased bilirubin is released. There may be thrombocytopenia, and there may be acute kidney injury. It is seen in the form of BUN and creatinine, BUN and creatinine. These three findings, and we may get treatment is treatment is blood treatment is fluid and electrolyte management, blood transfusion, and dialysis, blood transfusion, and dialysis. Then another topic, aviohemolytic disease. In aviohemolytic disease, what happens in aviohemolytic disease? Infants with the blood group A or B and infant with the blood group A or B born to a mother with a blood group O, born to a mother with a blood group O, jaundice within 24 hours of birth, anemia, reticulocyte count, hyperbilirubinemia, and positive Coombs test. Positive Coombs test, hyperbilirubinemia, increased reticulocyte count. There may be jaundice within 24 hours of birth. Management is serial bilirubin levels, oral hydration, and phototherapy for most neonates. Phototherapy for most neonates. Exchange transfusion for severe anemia. Exchange transfusion for severe anemia and hyperbilirubinemia. So treatment is what? Exchange transfusion for severe anemia, exchange transfusion for severe anemia and hyperbilirubinemia. Next topic is head, neck, squamous cell cancer. Malignancy is extremely likely in a patient with a persistent more than 2 weeks, palpable, more than 1.5 centimeter firm neck mass, firm 2 point more than 1.2 centimeter firm neck mass, who has a smoking history, and no preceding infection. By her, the most common malignancy to manifest in the upper cervical lymph node is mucosal head neck cancer. Mucosal head neck squamous cell carcinoma. Mucosal head neck squamous cell carcinoma. Head and neck squamous cell carcinoma in patients with in common with significantly use of alcohol and tobacco use. As this patient is alcoholic and tobacco user, it may cause these head neck squamous cell carcinoma. The first and the only apparent manifestation is palpable cervical lymph node, with which represents regional nodal metastasis, Identification of the primary source for squamous cell carcinoma is paramount importance because it directs all treatment direction. All the squamous cell carcinoma can originate from many sites: skin, uterine, cervix, upper esophagus, and a vast majority of the cervical nodal squamous cell cancer from the mucosal surface, the head neck cancer and nasopharynx through the examination. How will you diagnose? How can we diagnose this head neck squamous cell carcinoma by visualization using laryngopharyngoscopy? Laryngopharyngoscopy. So, persistent, palpable, firm neck mass, persistent, more than 2 weeks, palpable, more than 1.5 centimeter, and a firm neck mass with a history of smoking and the alcohol, and there is a regional cervical lymph node spread, and the diagnosis done. Head neck squamous cell cancer confirmed by seeing laryngopharyngoscopy. Hope you enjoyed.